Yeah.
All right. So as I said, we're going to do a roundtable. So there's going to be hopefully good dialogue. I'm going to indulge a little and hope to learn from you guys as much as you learned from me today. So the basic idea is, how can we create safe cultures in child welfare? And so I'm going to give you guys enough information, whether you've heard me talk, a couple of times or never, hopefully, to be able to respond to this question. And we're going to work through it together, and we'll break up into some small groups. So here's my basic plan for the day. I'm going to ground the work in system safety and reliability in the TCOM framework. So this is a TCOM conference, and I want to make sure you guys understand how this connects to TCOM and the use of the tools in the TCOM sort of framework. We're going to define and discuss a safety culture. So again, we can kind of level set so everybody knows what we mean when we use those words. And then we're going to discuss as a group or as groups, and then we'll come back and share some specific strategies we can maybe use in child welfare. And we're going to use a kind of a case study approach where I'm going to show you a video news clip that I know some of you have probably seen, certainly the folks on here from Tennessee, maybe new to the rest of you. I used to use it a lot. We used to use it in training a lot. It's just a little news clip about a fatality that happened in Oklahoma. Important caveat, it couldn't have happened in any of our systems, I believe. This particular news clip just happens to be really instructional on system response to high-profile events. So we're going to use that kind of as a case study for the work we do in the breakout session. Does that sound like an okay agenda for everybody? All right, I got a thumbs up from LA. All right, just some ground rules like participating in a session like this. Keep yourself muted. That's just a good, good for keeping you out of trouble and having an embarrassing Zoom moment. Turn on your webcams. Certainly leave them off if I'm just showing slides and talking, because I can only see a small subset of you on my screen anyway. But when we go into the breakout rooms, for sure, get on your webcam and interact with the few people that'll be in the breakout rooms with you. And then when we come back from the breakout rooms and we're having a discussion and a report out, it'd be great if everybody could be on camera and have that discussion. When I'm just doing slides, you can feel free to shut down. You can raise your hand, you can unmute. This is a small enough group. There's about 21 of us, I think. This is a small enough group. You can just kind of come off mute and say, hey, Mike, stop me, ask me a question. I'm completely comfortable with that. I probably will not effectively monitor the chat. So if you throw something in the chat, I might miss it. Lauren, are you able to monitor the chat? I don't know what exactly your role is on here. Lauren's on our team, so she's going to be helping us today, keeping me hopefully out of trouble.
I did get a ping that someone's waiting to be let in.
See, I lost that. I don't see it anymore. So let me go over here to mine. I just hit admit all. So, okay, I think that's. Oh, now we're up to like 31 folks. So,
and Mike, if someone sends a question, did you just want me to pop in and let you know?
Yeah, sure.
Okay.
I'm not going to come in and out of the breakout rooms, especially now that we're up to 31. We're going to have quite a few breakout rooms. And I've found in the trainings we've done using breakout rooms, it's just distracting when I come in. But if you have a question you want me to come in, just ask and I'll come back into into your break room. Just send a message. But otherwise, I won't be popping in and out. Plus, there's going to be several of them now. We're going to get into small groups. We'll have to create several, like 6 or so. And then when you're in the breakout room, maybe the person, I'm going to ask one of you to take notes. You might want to, screen share, take those notes in real time on a Word document. That there's not really much you're going to need to reference. I'm going to put the questions that will guide the breakout session into the chat room so you can have access to them while you're in the breakout. But, you might want to take advantage of screen sharing. It seems to help teams sometimes. It's almost like having a whiteboard to write on. All right, I'm gonna ask for, here's somebody else. I think we may skip introductions. That's my next slide. I was gonna have everyone kind of go around and say why you're here. I guess we could still do that if we did it really quickly. Maybe just a second or two, right? And what I'm most curious about is, just give me your name, where you're from, like Mike, University of Kentucky, and then your experience with safety culture. I have a little bit. And what you hope to get out of the day. just really quick, maybe 10 seconds, 15 seconds, and then we can get around it. It is going to be a conversation. You're going to be getting breakout rooms together later. We're going to be talking to one another. I think it's useful for us to kind of go around, and you're going to see each other throughout this great conference that we're having in sunny New Orleans this week. So what I'm going to do is stop screen sharing. And I am going to just call on people as I see them on my screen. And so actually, if I do that, you don't even have to say your name. I'll say your first name. You just kind of say whatever else you want to say after that. Lauren, you can role model and be the first one.
Sure. My name is Lauren Schmidt. I work with Mike at the IPH Center at the University of Kentucky, and I'll be moderating this Zoom session. So if you have any technical issues, feel free to pop into the chat and let me know.
And I guess actually I'll go second and not assume that everyone knows me. I'm Mike Cull. I'm with the Center for Innovation and Population Health at the University of Kentucky. I do support CANS implementations around the country, but I also do a bucket of work around applying safety science in child welfare systems and supporting a tool that we've developed that's similar to the CANS, if that's, or the ANSA, if that's your exposure to the TCOM work. And I'm going to talk about it today. Stephanie Waldschlager.
Hi, I'm Stephanie Waldschlager. I am a CANS consultant in the Tennessee area. I would say that I'm moderately familiar with the safety culture. I have worked as a private provider, and now, like I said, I'm doing CANS consulting. Just happy to be here.
All right, thanks. See, both of them kept it really quick. This is going to get us through it. Tammy from Oregon.
Really quick, Tammy Kane-Suleiman. Hi, everyone, from Oregon. And child fatality prevention and review program manager. And really quick, I'm here because two of my employees, amazing employees who are also on this call, submitted a proposal to offer a session on safety culture this week, and they were accepted. So we're on Friday. Join us. And am I missing anything? We do safety culture in our critical incident review teams, and so I wouldn't say we're experts, but we have a pretty good idea of how they work, how safety culture works within that constraint. And I think my goal is just to be able to understand how to spread the joy across the entire child welfare agency. So hoping to get some great ideas today.
Thank you. And you make a shameless plug for her talk. Sophia?
Hi, everybody. I'm Sophia Baca Gutierrez. I'm with LA County Department of Children and Family Services. I would say that I'm moderately familiar because Mike has been doing an awesome job with us over the last, year or 2 years on this topic. And I'm hoping that I'm going to be able to get just where everybody's at with their implementation of safety culture. So thanks for letting me be here.
Thanks, Sophia. Amy?
Amy Dixon from Oregon. I'm one of Tammy's employees. And our work with safety culture began in Oregon about 2 years ago. But I also have about 11 years of TCOM experience. I used to be a CANS coordinator for the state of Oregon.
Thanks. Tracy Stovall.
Hi, everybody. I'm Tracy Stovall. I'm from Tennessee, work for the Vanderbilt Center of Excellence, and my role is a CANS and FAST consultant and work directly with the Tennessee Department of Children's Services staff on completing those assessments.
Kathy Gracie showed me that video you guys made. It's amazing. Steve Plum.
Hi, my name is Steve Plume. I am a CANS trainer and consultant with the University of Illinois at the School of Social Work there, and only moderately familiar with the safety culture and hope to learn more.
Cool. I'm really interested to hear what this CANS, the folks who haven't had as much exposure but are, have a lot of CANS experience. Scott Fairhurst, I jumped over to you, but now that you're back, you want to begin?
And I'll be introducing myself, I'm guessing?
Yeah, just real quick, like just your name and why you're here.
Got it. I'm Scott Fairhurst. I work with Pacific Clinics in Southern California, and I'm here to see how we can use CANS data to keep an eye on kids who might be at risk for suicide, self-harm, and danger to others. I
hope you're in the right session. There's one on data analytics, on like algorithms. Is that the one you meant to be in, or the safety culture one?
No, I think I'm in this one. I think I want to be in
Okay.
this one.
Maybe you mean you're just here for the whole week for that reason? Okay.
Yes.
Sarah Duncan.
Hi there. I'm with the Northern Academy through UC Davis. We're one of 4 regional training academies in California, and we provide training and implementation support to 28 northern counties. And I'm the CANS lead for my agency. And so I don't know a lot about safety culture, so I'm very intrigued. And now that I know that LA is like, you know, been doing it for 2 years, I'm feeling a little competitive. So thanks.
Really kind of more than that. I think it's been probably 5 or 6 years since I came out there first. Ellen?
Hi, Ellen Kenoy. I'm from Lincoln Families in Oakland. I'm part of the Alameda County CANS Collaborative, and I'm new to safety culture, I think. I'm not sure. And I'm curious, so that's why I'm here.
Cool. Molly Miller?
Sorry about that. I'm Molly Miller. I am the other Oregon counterpart here, and so I don't have a lot to add other than I'm just a part of that team.
Thanks, Molly. Jorge?
I'm Jorge Sanchez. I'm a social worker for Casey Family Programs in Yakima, and we're a proud sponsor, and I've been a user for about 2 years now. And my experience with safety cultures, I would say it's about 50%.
Great. Fran Daniels-Moses.
Hi, I'm Fran Daniels-Moses. I am a CANS and FAST consultant in Tennessee with the Center of Excellence at Vanderbilt. I feel I'm pretty safety culture wise. I would say I'm moderate. Been doing this position for about 16 years now.
Awesome. Jordan.
I am Jordan Constantine with Affinity Consulting, currently working with Mike and the Safe Systems team at the University of Kentucky, offering technical support around critical incident reviews.
Melanie and Friend.
There we go.
I'm like a Melanie Akins and Candy
Glasscock.
We're organizational cultures and safety systems analysts with the Department of Human Services in Tennessee, and we are just here to grow our knowledge.
It's so great. We have people on the absolutely both ends of the spectrum in terms of their exposure to this work. So it's going to be fun, I think, when we get into groups. Except I'm going to assign you randomly, and so naturally all the Tennessee folks will end up in one group. Heather Copeland.
Hi, I'm Heather Copeland. I'm with San Bernardino County Department of Behavioral Health, and I'm just here to learn about the safety culture.
So for those of you that are primarily in a behavioral health sort of context, I'll use child welfare examples just out of sheer habit. I worked in community mental health. I had a practice. I had administrative roles. That's how I got connected to child welfare. So I definitely have that background. But I haven't done it in a long time. And so I'll mostly make child welfare references. And this work of creating a safety culture applies really naturally in these safety critical settings where you're making high risk decisions like removing a kid or leaving a kid. A little more challenge to apply it in an outpatient mental health sort of setting, but not impossible. I actually did a webinar for Texas Behavioral Health just maybe 2 weeks ago. So that's just a little apology in advance if I use nothing but child welfare examples. Tara Woods.
Hello, I am Tara Woods. I am a foster care program director with a company called NECO. My office is located in West Virginia. I am pretty familiar with the safety. This is what I do on a daily basis with just like risk for our children. We do CANS assessments quite frequently, but I think there's always room for growth on how to continue to provide safety in those environments.
Awesome, thanks. Christina.
Hey, I'm Christina Fly. I am with Affinity Consulting and a part of the Safe Systems team at UK. I've been working with safety science and safety systems since 2012, Mike. We've been doing it together for a long time. and have worked with CAN since, I think, implementation in 2006. So excited to be a part of the conversation.
Thanks for being here. Miranda Creech.
Hey there, I'm from South Carolina, and I'm the manager for child fatalities there. And like Tammy, I think that I'm here just to learn more about kind of spreading safety culture throughout the system.
Miranda works for the very first CANS consultant we hired at Vanderbilt.
Yep.
Kelsey Nay. If I skip somebody, just let me know, because as people came in, it jumped around a little bit, and I might have missed some folks.
Kelsey Nye. I am a Quality Improvement Director for Seneca Family of Agencies, which is primarily in California, and I'm part of the Alameda CANS Collaborative with my friend Ellen down there. I'm fairly new to safety culture. I manage our Joint Commission accreditation, and safety culture seems to be a hot topic, so I want to learn as much as I can and be prepared for that.
That's very cool. So I use Joint Commission a lot as an example, because we're doing this work in a lot of child welfare systems, and it was, in my perspective, and all everything I know about safety culture comes out of a healthcare context. It was when Joint Commission got on board and started requiring things of hospitals that were related to that work that hospitals got serious about it. Have you been at Seneca for a while?
Yeah.
Did you know Darren Dixon?
Yeah.
My kids went to his school that he and his brother started here in Nashville.
Oh, very cool. Yeah.
Ashley Rice.
Hello, everybody. My name is Ashley, and I am also from Tennessee and work for the Center of Excellence of Vanderbilt and work directly with the Department of Children's Services and the implementation of the CANS in the past here in the state of Tennessee.
Thanks. Ashley. Nate.
Hi, I am Nate Lubold. I'm the Director of Training and Implementation with an organization called Advanced Metrics. We are a B Corp that specializes in developing outcome-based software. I've been working with the CANS since about 2003 when I became a clinician. So before coming to the technology side of the business, I worked in treatment foster care for a number of years. Still working in the field of human services, just from a little different vantage point.
Yeah, sure. Thanks.
I'm really looking to for this to see how to. I think we've always talked about safety culture, but how to have more formalized conversations within the organization.
Perfect. Priya. Sorry if I messed that up.
Hi, this is Priya Tharayo. I'm with DPH San Bernardino County as well, and I'm also getting introduced to safety culture.
I was going between Priya and Priya, and I knew I would pick the wrong one, so.
That's okay.
Try to get it right next time. Santana Jones.
Hi, let me get my video going. I'm sorry. I'm Santana Jones. I also work with South Carolina with Miranda Creech, and I'm here to learn so that we can spread safety culture throughout South Carolina. I'm so glad to be here.
Love it. Shante? Okay, I'm going to assume if you're not on camera, you might have stepped away. So I'm going to move on. Amani? You're on mute, Amani.
Thank you. Hello.
I do that like 10 times a day.
Yeah, I'm Amani. I'm a children's social worker in LA County Department of Children and Family Services. And I'm really just trying to learn more about safety culture and how, as a CSW, I can possibly implement that in the different roles that I do in both the office and outside.
Thanks. Shalisa Foster.
Hi, everybody. As you said, I'm Shalisa Foster. I'm the Chief Operating Officer for a care management organization in Bergen County, New Jersey. We're part of the New Jersey Children's System of Care. our youth who we work with have high or complex needs, considered higher in the county. About 20% of our youth are co-enrolled with our Child Welfare Protective Services. And we are also the organization that would facilitate out-of-home treatment should our child and family team for that youth decide that. So, you know, safety culture is always one of those important aspects that we're working with for our population of youth that we work with.
Thank you. Cameron?
Cameron let me know she's having some audio issues.
Oh, okay.
There she is.
I think I can hear you. I'm so sorry. I was having some connectivity issues.
We can hear you.
Of safety analyst out of the Grand West region.
All right, thanks, Cameron. I think you are having some bandwidth issues. Maybe you broke up on me at least. All right, let's get rolling. Thanks for doing that. That helps me a ton. I know it takes up a little bit of time. We've got time, and I've built a really flexible sort of slide set and activities. So we'll hopefully you'll get out of this what you want to get out of it. We do have a really diverse group of people, both where you work, the kind of work you do, your experience with what I'm going to talk about. So that'll be fun when we get into the breakouts, I think. Those of you who've seen it know, but the video that I'll show you that we're going to use kind of as a case study is a news clip about a child fatality that happened in Oklahoma. So it's a little troubling. So we'll do a little exercise after it. You can debrief with the folks in that breakout room, and then we'll take a quick break right afterwards so everybody can decompress. We'll come back and wrap up. In case you didn't know, you're at a TCOM conference. So I wanted to try to ground this work in TCOM and so that you understand why I'm talking to you about this idea of safety culture at a conference where largely people are talking about things like the CANs and the ANSA. So TCOM is this overarching framework. It's, I think, important to revisit the idea that when you've committed to using those tools, CANs, the ANSA, the variety of tools and systems, you've committed really to an outcomes management strategy. Transformational collaborative outcomes management. So at the end of the day, what John created when he started working on these tools and working with systems to develop these tools was an approach to using a family story, stringing it together with all the other stories in your system so you could get better outcomes across your system, so you could manage more effectively. It has within it sort of this overarching philosophy that we base all our decisions on the shared vision, on that family story, and our understanding of the work we're going to do together. And then we have a set of strategies, tactics, and techniques. And so we talk about the strategies as being actually the tools we use. So the CANs is a strategy in the TCOM framework. It's better thought of as a communication strategy, frankly, than it is as an assessment tool, because you're not sitting down and assessing a family with a CANs or an ANSA in the adult population or any of the other tools that we use. You're having a conversation and helping a family tell their story so you can capture it in the CANs. And then you can use that information to advocate for their care, to work with them, and then ultimately to manage outcomes in your system. We've developed recently this tool called the SSIT, the Safe Systems Improvement Tool. And a number of the folks on the call are using that tool in child welfare settings to support child fatality, near fatality reviews, and critical incident reviews. And it functions, I'm going to show you an example of it after we come back from break, but it functions in a similar way to the CANs in that it helps a system organize important information. Just in the case of the SSIT, it's not things like depression and anxiety and parental substance abuse, it's things like teamwork, fatigue, stress, production pressure, those things that influence decision-making in our workforce, and you're using it in the context of a critical incident. So something's happened. We have an obligation to go find out what our role was or was not in it and how we can improve our system coming out of it, child fatality or other critical incident. And this tool, the SSIT, helps you organize that important information. So one, you can do work on that, responding to that particular critical incident, but more importantly, so just like the cans and the ANSA, you can take that story about that critical incident and begin to string it together with all the other stories about critical incidents in your system. And so, in as much as it's an outcomes management strategy, we talk about this sort of this grid of activities, the idea that you can take CANS information and use it at multiple levels of your system and in multiple ways. It's a strategy for taking that shared vision, the family story, aggregating it throughout your system and using it in different ways. So down at the client or family level, you're using that information to make decisions about what kind of action planning we're going to do together, what kind of evidence-based practices might be appropriate for you. At that client family level, you're using it to do outcomes monitoring, like are we doing service transitions when we need to and celebrating successes when we need to. And then we can use it even at that level for quality improvement. And then you can imagine, think about moving left to right on this grid and even up to down on this grid as being the process of aggregating data at different levels. So at the program level, we're going to bring together all the kids' CANS data in a particular program, and we're going to use it to help evaluate outcomes or help match kids to certain services, or in our COA accreditation efforts. And then at the system level, it's going to help us make decisions about how we manage our system, how we right size for based on the resources we have, how we build different business models that are more maybe effective and efficient and targeted at the needs of the family, needs of the kid, needs of the adult in an adult setting. So this sort of grid of activities becomes the strategy we use for taking CANS data or ANSA data or FAST data, aggregating it to make outcomes decisions in our system. All right, so what's important for the rest of the talk, and definitely for this next slide, is keep in mind that that aggregating starts with one team or one professional, maybe in the behavioral health setting, completing a CANS. So it's one professional taking that important information and doing something with it, putting it into the CANS so it can be used. And so then it becomes important to think about, we're taking that one story that one professional completed and tying it together with ones that lots of other professionals completed. And so the reason that's important is because at the core of thinking about a safety culture is thinking about how people make decisions in complex settings. What things influence the way our professionals are making the decisions they're making when outcomes are safety critical. As I said, this work applies best in settings like aviation and healthcare and child welfare, where people are making these high consequence, high risk decisions, all day long, and they can't really learn by failing. So we have to build systems that support better decision making. And so if you think about that grid, not as a grid, but as a funnel, that down at the point of the funnel or the pyramid upside down is that individual making that first decision, or that team, hopefully, because we support collaborative decision making in the TCOM model, making that collaborative decision about what's going to go into that CANS, what work are we going to do together, how are we going to take that story from multiple perspectives and summarize it into the CANS so we can use it. So down at the point is that one person making that decision, and then you're going to aggregate up and out in the TCOM model, and you're going to begin putting those stories together and using them at different levels of your system. And so from the perspective of how do we think about a safety culture and professionals making decisions in a complex setting, what you then need to bring to that thing that's going on right now in your head where you're thinking about that one person sitting there making decisions is what influences their ability to be really effective at doing that assessment, at understanding that family's story, and at using the CANS. And the kinds of things we talk about are, what's the role of production pressure on making these decisions? What's my caseload? How busy are we? How many referrals did I get this week? Because that's pressing in on my ability to do good work potentially. We know the work comes with a certain amount of exposure to other people's trauma. We're in the helping profession where we're dealing with people who come to us because they need to go through some sort of transformation. They're not where they want to be right now, and we're there to help them go from where they are to where they want to be. And so trauma exposure is a big deal, and we know it affects folks in our line of work in a particular kind of way, and it can affect the way we make decisions. We know we bring cognitive biases to our work, and it affects variability. Cognitive biases are those things we're just sort of wired with as humans, things like hindsight bias, where once we know an outcome, we look back at the events and we put them together in some logical sequence that didn't exist for the people who are actually making the decisions on that day. or confirmation bias, a really important one in clinical work, where we look for data and we're more persuaded by data that confirms our own assumptions about a case or a kid or a parent. We devalue evidence that would disconfirm our assumptions. And that's just being human. It's how we're wired, right? So this affects the way we're making decisions down here at the point of the spear, as it were. And then we know stress and fatigue are a big deal. Burnout is really high in the helping professions across them, certainly in child welfare. We do a lot of organizational assessment work across the country, a lot of different child welfare jurisdictions. And I've done similar work in hospitals. And that burnout number, you know, it hovers around 45, 50%, just sort of consistently when we go measure a system or a hospital system. So we know there are all these things in the environment and things that just come along with being a human being that affect the way we do things and make decisions inside complex systems. And so then if you think about this grid of activities as a strategy, you have to think about it in context. And the context we're going to talk about is, what's the organizational culture that supports or doesn't support being effective at doing this kind of work? Because if that's our strategy, this quote you've probably all seen some version of, this idea that a culture eats strategy for lunch, is really true. We can take our best laid plans, our, you know, what we intend to do, this really fancy tool that John Lyons got started and that, you know, this large national collaborative helped refine, and all the things that have grown from that, and drop it into a culture that eats it, that keeps it from being effective and keeps it from sort of maximizing its potential. And so what we know about culture, and what I'm going to talk to you about, is a particular kind of culture that we think is has great promise in improving child welfare and other helping professions, certainly behavioral health settings, certainly congregate care settings. We think it has great potential for improving those settings in the same way that it's been effective at making places like healthcare, operating room, or the cockpit of an airplane, or the deck of an aircraft carrier, making those places more safe, reliable, and effective, because that's sort of our goal, right? Being safe for us as professionals, as for the folks we're helping, being effective and being reliable, being able to get those outcomes reliably over time. So we don't think of culture as this sort of abstract idea. Culture is something that we know when we see, we can measure it, and we also think we can change it, because culture lives in an organization's habits and how it solves problems. And so we can affect habits, and we can affect problem solving. We can help people think about error or variability in their systems, things like child fatalities that happen that we don't want to happen, differently, and solve problems around those things in a different sort of way. And then we can help teams develop different habits that support a particular kind of culture. So what is culture? Edgar Schein's done probably the bulk of the early writing on organizational cultures. He would be looked to as, you know, sort of a guy to get a definition from. So I'm going to grab his. It's this sort of pattern of shared basic assumptions. It's, again, how we solve problems in our systems. And it's what we teach to new members. It's what, again, it's our habits. So I know I've experienced this a number of times over my career, and I'm sure others have too, this experience where a new professional comes in, maybe a newly minted therapist comes into the mental health center, or a new social worker comes in after pre-service training and meets the senior supervisor they're going to be working for or with, and they're doing something, and the conversation goes something like this. I know that's what they taught you to do, but this is how we really do it around here, right? That's culture. How we do things are habits, not our strategies. Strategies are about planning and intent. Culture is about habit and how we solve problems. So what we're going to talk about is, how do we create a context that would allow a certain kind of culture to flourish in our systems? Because we know those kinds of cultures, when observed in other safety critical settings, result in better, safer outcomes. And so what I'm going to be talking about and toggling back and forth between is this idea of safety science, or applying safety science to our settings, and how we get this idea of a safety culture. What is a safety culture? So the Agency for Healthcare Research and Quality is a part of the Department of Health and Human Services, and this is how they define a safety culture. And they're responsible for a lot of work in helping hospitals sort of achieve this goal of creating a safety culture. And they provide the safety culture survey tool or organizational assessment tool that's most widely used by hospitals. Most hospitals use it. And actually, the Joint Commission, who I mentioned in response to somebody's introduction earlier, the Joint Commission, as part of their work in accrediting hospitals, actually requires hospitals to do a safety culture survey on a certain schedule, and they require them to use the results in a certain way. So a safety culture is an organizational culture that acknowledges the high-risk nature of an organization's work, and it is determined to achieve consistently safe operations. It's about reliability and getting consistently safe outcomes. This is a really critical piece of a safety culture. It's about promoting a blame-free environment. We need to create environments that are safe for people to learn within. And so we therefore need to shift from a culture that thinks in terms of errors, blame, reprimand, that will somehow motivate safer, more effective behavior, to one that understands that when we blame people and shame them, they go underground, they don't talk about their mistakes, they become fear-based, right? Very, very important piece of this work is shifting from a blame and shame sort of environment, which in at least child welfare, we've had a long history of, to one that's about positive accountability for sure. It's not about not holding people accountable, but moving towards a place that's about learning. It encourages a collaboration across ranks and disciplines. It's in the literature, there's this idea of deference to expertise. So we're going to employ knowledge from anybody within our system without regard for our hierarchy, their title, their degrees, their status. So we're going to build a system where everybody is involved in keeping people safe and sort of being effective at the work we do. And the idea of collaborative work fits really nicely into the TCOM framework, right? Because we want collaborative decision making when we're talking about using a tool like the CANS or ANSET. The best way to use it is not sort of the individual professional going down and doing an interview and rating it. So what we struggle with sometimes in settings like outpatient behavioral health, certainly in child welfare, is we don't organize ourselves into teams often. Other safety critical settings have long understood that collaborative decision making is a safer, more effective model for decision making, but we still kind of cling to individual decision making in some of these other settings. And then the organization has to be about committing resources to safety concerns. It has to direct resources at safety and make safety an urgent priority in their organization. Not just safety for kids, which we talk about a lot in child welfare, or for adults in an outpatient setting when we're concerned about suicide rates, but safety for our professionals that are doing the work, because they can't be effective in their work if they don't feel both physically and psychologically safe.
Thanks, sorry to interrupt. There's just someone waiting in the waiting room.
Oh, sorry, it pops up over here and I don't see it. Well, one of them's Molly. She must have gotten kicked out. Okay. Thanks, Molly. So leaders and teams have some very specific set of responsibilities within a safety culture. Leaders have to strive to balance this idea of systems and individual accountability. When something goes wrong, is it an individual's is primarily responsible, which is a very small percentage of the time, frankly, and when is it a systems issue? And where is it sort of in between? Because it's kind of a balance, but there's always a little bit involved. They value open communication, transparency, and continuous learning and improvement. We have to be about learning and improving to create a safety culture. And then, as I said, organizing into teams is a more effective way to make safer decisions. And so teams have a specific set of responsibilities. They monitor themselves, their colleagues, and their systems for signs of stress. We have to be about that sort of understanding when our colleagues need support, understanding when things are putting our system or creating system pressures that are going to affect the way we make decisions. And then they have to be able to organize in such a way that they anticipate and respond to unexpected events. This is about creating system level resilience by creating teams that are effective at making those kinds of decisions. And so, as I said, we borrow a lot of this work that we're doing from these other safety critical settings. We borrow a lot of the tools and a lot of the strategies we're starting to apply in places like child welfare and congregate care from places like healthcare, commercial aviation, and nuclear power, where they do a lot of the kinds of things I'm talking about in a very reliable way. They get consistently safe outcomes over long periods of time without significant failure. Okay, that's a quick high-level overview of just definitionally what is a safety culture. Now I'm going to show you the video clip I told you I was going to show you. So I'm going to have to drop my screen down for a minute. And we're going to come back after watching. It's only about 4 minutes. Debrief it for a second. I'm going to give you a little more information that I've gotten from some of the public documents about the case. And then we're going to break up into our breakout rooms and spend, maybe 15 minutes answering 4 questions. All right, I'm hoping this works.
But first, another state agency joins the investigation into a little girl's death. I'm Paul Folger.
I'm Jessica Shambach. Sean Brooks is accused of killing his 5-year-old daughter, Serenity Deal. Investigators claim DHS withheld important information about the case, so now they're asking OSBI to investigate. Eyewitness News 5's Jessica Holloway is live with this big story. Jessica?
Well, it all started when Serenity's mom was accused of molesting a young boy, so DHS intervened and placed her with her father. But now a district attorney has filed a letter asking OSBI agents to figure out why that ever happened, when he says there were signs of abuse and Serenity had been injured twice before when staying overnight with her father.
The investigation may one day come to an end, but for Serenity Deal's former foster mother, the pain will never stop.
She, in the beginning, was excited to have a dad. She had never had a dad.
5-year-old Serenity was found with injuries to her face, head, back, stomach, and bruises all over her body. Police removed a bloody child's mattress from her dad's home. Sean Brooks said Serenity fell in the bathtub. Prosecutors charged him with beating and killing her. According to an internal DHS investigation, caseworkers failed to look into the father, Sean Brooks' history. Specifically, they never questioned the child's mother until after the 5-year-old died.
And employees will be held accountable for not following policy.
Potawatomi County District Attorney Richard Smotherman believes DHS withheld information from his office, like stacks of concerned letters written by her foster mother. Smotherman's calling on OSBI to assist in a criminal inquiry. In a letter to OSBI, he writes, quote, "The focus of the investigation will be on the actions and inactions of all the parties involved in the custody and placement of Serenity Deal prior to her death."
And that information was never given to the court, was never given to my office, which is inexcusable.
This case enrages the state Speaker of the House, Chris Steele. He's calling for an agency-wide investigation as a result of Serenity's death.
Hopefully we will be proposing policies next year that will not only address this situation, but make sure that Oklahoma is doing everything it can within its power to protect our children.
It's too late for Serenity, but this foster mother hopes the efforts of all these adults will help save another child.
The caseworkers are told to close the case. Get this child back home.
And Chris Steele says several lawmakers here are on board with trying to make new policies in regards to this case. Now, I tried contacting several of the employees that have been put on administrative leave since this happened to hear their side of the story. So far, they have not returned our calls. Reporting live tonight, Jessica Holloway, Eyewitness News 5.
Thank you, Jessica. And 4 caseworkers were put on leave after Serenity's death. 1 resigned, another committed suicide. The other 2 are now going through the termination process.
So, always a really tough video to watch, and I've seen it so many times now. Obviously, especially
if it's just a registration issue, they'll back off completely, especially when you're swerving in and out of traffic.
Okay, let me get myself back organized. So, again, that video, when I use it, is not about Oklahoma. This could have happened in any jurisdiction, I suspect. It's just, it has some amazing little teaching points in it. Like when the public information officer says staff will be held accountable for not following policy, and just a lot of finger pointing, right? A lot of shaming and a lot of blaming before they really had an understanding what went on in the case. I pulled just a little timeline out of the public documents, and just to give you an idea of some of the details. First referral was in 2009. It wasn't about abuse. It was about the mother was molesting another relative. The safety placement at the time was just a place with grandmother. In 2010, Serenity was back with the mom and a boyfriend. The grandmother had allowed her to go back, and so they removed her to custody at this time. And then around September, a biological father was identified, and this is I'm blanking on his name, but he's the one that ultimately murdered Serenity. So they identify biological father. He had not had custody previously. They start the process of reunification with him. She has some injuries during an unsupervised visit that they deemed to be consistent with the story. It was fairly minor stuff, and they screened that out in January of 2011. So we're 2 years down the road now about.
All right, Zorin, we're coming to the pursuit anyways.
It started time. Sorry, guys.
Cell Park. That's Cell Park.
There we go. I did not make a high-speed pursuit part of my talk today. January 4th, injured, unsupervised visit. It was screened out. And then January 21st, a few weeks later, after an extended visit, she comes back with significant injuries, but the emergency department clears her. Feels like the injuries are consistent with the story of a fall that they provided. So in February, there's a trial reunification approved. March, the assessment by the child welfare system recommends reunification. Feels like dad's a safe placement. April, the child and family team together sets a reunification date for the first. And when I say in February, the trial reunification is approved, that's by the courts, of course. And then they set it for June 1st. By June 4th, the referral comes in that is the one around Serenity's death. So this is the overall timeline. It plays out from 2009 to 2011. You see there's some pretty big periods where things are pretty stable, especially from January to June, 6 months of what's relative common safety. And so an important update to this case for you guys, the district attorney that you saw in the video clip, DA Smotherman, came out publicly. They found nothing in the investigation. Everybody was exonerated, including Donald Wheeler, who was the social worker who committed suicide. Okay. I'm going to post this into the chat room, if I can figure out how to do that. Okay, I just posted these 4 questions into the chat. And so what we're going to do, I think there are 30 of us. So I'm going to do 6 breakout rooms. So you have about 5 in your breakout room. When you get into the breakout room, somebody please volunteer to take notes. And then that person can either also be the person that comes back to the group and reports out on what you discussed, how you answered these questions. Or you can break that up. One person can take notes and one person can be the person that volunteers to report out. Does that sound good? If you happen to get into a room and literally it's like everyone from Oregon or everyone from Tennessee, let me know and I'll mix up the rooms a little bit. So 4 questions. Could this have occurred in your system? If you're not working in child welfare, think about in an outpatient behavioral health setting where there's a high-profile suicide of someone you had taken care of. What did you see in the way this system responded in some of those, reactions and the finger pointing and stuff? How would you feel if it happened on your caseload? And then what do you think the impact would be on a system, on like practice in general, when a system responds in this way? Do you think this has any impact on the rest of the workforce and the kind of work that they do? Any questions? All right, I'm going to stop sharing. All right, you're about to get put into one of 6 breakouts. And let's see, it's 2:52. Let's do this for 15 minutes. Does that sound like enough time? Do 15 and then we'll come back, we'll debrief it, and we'll take a little break. All right, so here's something I didn't plan for. So you guys are just gonna have to volunteer to give your report out because I don't have a way of knowing how to call on people that are gonna report out. Generally, how'd the breakout rooms go? All right, who wants to go first? Now that all these people with thumbs up, one of you needs to step up.
I think our group was group 1, Mike.
All right. Oh, that's a good. I could do it that way, couldn't I?
Okay.
Let's go group 1 through 6. Thanks. Trey.
Okay. I think I took the notes for group 1. So what we came up with in talking is, yeah, we felt like it could happen in the system. You know, we talked about the number of pressures within systems and feeling like there's a rush oftentimes and seeming to try to meet needs, hit metrics, so to speak, you return homes and getting kids back to their parents. And as such, a lot of red flags are missed in those processes. You know, and also looking at things like case size, you know, caseload sizes and all the expectations for put on the individuals working, the pressure to avoid long stayers and the like. You know, what we saw in the system's response was instantly a sense of who's responsible, who can we pin this on. That seemed to be the approach, and we, you know, and ultimately this idea that, you know, somebody has to be to blame, and that might be a bigger even cultural issue for the news media needing to, you know, and those that are watching the news wanting to figure out who we can blame. And of course, how would we feel if this happened? Devastating for sure. And I think we've talked about how, you know, no matter your involvement, you would be in a situation where you would wonder, and you know, did I miss something? Was there a red flag I missed? It would bring a lot of questioning, and that, you know, from there, what would happen is, what impact is, you know, certainly people would be very cautious moving forward, certainly be new policies and procedures and new ways of going about things, and probably a whole lot of questioning about whether people want to stay in the field or not, and pushing people to the point where they may actually want to leave. And as was sadly stated in the video, you know, one of the caseworkers committed suicide. So that was brought up too. So in a nutshell, that's kind of what we hit upon. Please, Team 1, if I missed anything, feel free to chime in. I may have. So
No, you rocked it. Awesome.
I rocked it?
Yeah.
You rocked it.
Thank you.
I think, yeah, Team 1 set the bar high. I asked the question about, you know, how would you feel because I think that's how most people would feel, right? Devastated. And we lose that oftentimes in our response to these kinds of cases. We lose the fact that the people working the case work in child welfare. They get up every day to take care of kids and families. They're oftentimes very connected to these kids and these families, and they feel a tremendous sense of loss in addition to all the other stuff you discussed, which is like, oh my gosh, what was my role in this? And people generally overstate their role in these kinds of things and need systems that help balance that kind of that reaction to overstating your role in a case like this. And then, yeah, we jump quickly to we feel the need to blame somebody. It had to have been someone's fault, right? These things can't just happen as a consequence of our systems. It had to be somebody's fault. Yeah, I think you guys really nailed it. It was a lot of really good points. Team 2. I've turned you into a team now. You're not just a breakout room. You're a team.
I was in breakout room 2. This is Amy, and I was the note taker. So I will, and the designated talker. So I'll go ahead. We had a lot of really similar discussions to what Steve described, but some kind of, I think, additional pieces from our group was, you know, could this occur in your system? And of course, everybody said yes, but then also thinking about, you know, the realities that it's already a looming fear, right? So not only, you know, do you see a story like that and think, oh my gosh, this could happen, but it's already a fear that people possess. And that's across human services, I think, child welfare, behavioral health, juvenile justice, right? We kind of talked about that Sunday scaries, right? Where you go to bed on Sunday night knowing you have to go back to work on Monday and you hope that you made all the right decisions on Friday, and how hard that is. We talked about the shame and blame and the system response, but also this really quick reaction. So immediately in the news saying we're going to hold people accountable versus stepping back and saying, you know what, we aren't going to comment on this until we've had time to reflect and learn and understand what really happened. And that, you know, that really stands out. And I think that's a common occurrence. of course, the devastation, right? I think you're so right about that, Mike, is that we lose that piece around how people really feel when a negative thing happens on their caseload, especially the death of a child or a client in general. And then the impact might a response like this have on practice in general? So we talked about, that you don't feel like you can make any mistakes or have room to learn from any of your experiences, right? If that's the reaction when something bad happens, then I better just be perfect all the time. One of our participants talked about reading comments on news articles after a significant event in their state and how this realization of how the public has a really negative perception of child welfare workers and how that feels, right? And that you may lose people who are really good at their jobs because they cannot handle that. And then the final piece of really, we become more risk averse, right? You see placements go up when you have a significant event. It's not uncommon at all to see that trajectory, right, of placements and petitions in court go up because people are worried to make the wrong decision.
Yeah, all great points. And like I think about that reaction, the shame and blame sort of response from the system where the public information officer said people will be held accountable for not following policy. In some of the systems that have been doing this work for a while, and you are starting to see a different response. I'm thinking about LA County, I think, not long ago, and a response from LA County that the language is just different that comes out. It says it acknowledges first the tragedy. It's kind of a tragedy for everyone, including people involved, and it creates some space. It doesn't single anyone out. It doesn't throw anybody under the bus. And then, yeah, you're exactly right. When these things happen, our workforce can become really fear-based. They go underground. One, they don't talk about things that they're seeing in their system that need improvement. But two, to Amy's point, they become more conservative and less likely to trust reunification efforts. And so they're just more likely to bring kids into custody. You're going to likely to see spikes after these high-profile events. Awesome, thank you. Team 3.
We're team 3, and we had very similar conversations within our group. We agreed that this could happen in systems, and all of our systems. I think some of the different conversations we had is what kind of impact it can have on our systems, such as that, like turnover rate after maybe something so devastating after this happening, the emotional impact that it will also have on the system after something like this could happen, and how it also impacts our policy and procedures when something as devastating as this can happen. So that's maybe a different piece that we talked about, because I think that this does create a lot of fear within workers and within the system in general, because our main goal is to keep children and families safe.
That's a great one. I'm glad you brought that one up. This idea that we make significant policy changes in our systems. That legislator in Oklahoma was going to go write some new laws because apparently there aren't enough laws that make it illegal to kill a kid, right? So the knee-jerk reaction to responding to one case, one high-profile case, and writing a bunch of policies is really, really troubling. And we tend to aggregate those things, right? We do it when it happens, and then it happens again, and we do it again. And we don't change the old policies, we just add new ones, and we just get our systems get more and more complicated. Because I'm sure all of you and all of your systems know exactly how to follow every single policy, right? Because you only have 3 or 4 policies you need to remember. We have thousands in most systems, and many of them are probably in conflict with one another. So that response to this bad thing happened, we got to go write some new policies, train people to do something different. It really can create complexities in our system that make it less safe. Okay, team 4.
So I'm reporting for team 4. So we definitely said this can happen in our system, but what we also talked about was some responses to the system, how for South Carolina and both LA DCFS, they had child fatality teams that do look at scenarios afterwards to see what went wrong, as well as a high risk team that looks at scenarios where there wasn't a fatality, but what was either done right or what prevented such devastating acts to follow. In the response from the systems, again, we said to blame the workers because they said heads will roll in the video, and they approached it from more of an individual instead of a systematic approach, blaming the workers. And they pointed out that one worker killed himself, but it was kind of like a caveat, like a quick little statement. And it's like, well, okay, that's another life that we have lost based on not only the incident, but how we responded and the pressure that that individual felt, not just from work, but society as well. And how we often don't look at how this also affects the workers. How would you feel if this happened on your caseload? Scared, less inclined to do this work, possibly quit the entire system and betray it, because most of us are purpose driven doing this job, and you give yourself a lot for the org to then blame you when something happens, before even looking at what could have been done or what you did right versus what happened and what was out of your control. And then what impact might this response have on practice in general? Looking at workers through a magnifying glass or microscope, again, instead of a systematic approach, it feels more anxiety provoking. You can be walking on eggshells as a worker, trying not to make a mistake, overly looking for small things, which again can lead to fearful working and either have more children in the system, less likely to reunify based on small things. And then this can also even increase biases that people have and stereotypes versus different family, races, ethnicities, religions, and stuff like that. It becomes a more CYA, cover your ass work environment. And then demonizing workers instead of systematic approaches.
That's perfect. I'm glad you told me what CYA meant. I've wondered for years. Yeah, awesome points. I hate to like single out Oklahoma as if this was like, I actually, our public information officer, when I worked at Tennessee, knew the public information officer that's in that clip that says, people will be held accountable. And he assures me that she's a really nice person and a very competent professional. But the heads are going to roll sort of vibe that comes out of that news clip is so instructive. Like you guys have kind of all so far touched on that, that's what you got from it when you watched it. And it's not uncommon for us to see news clips like that. And so really, really good stuff. So am I up to 5, team 5? Or you were 4, right, Amani?
Yes, I was.
I think we are team 5, Mike, and I'm going to apologize because I'm supposed to be reporting out, and I know my internet connection is struggling today. So,
so far it's good.
All right. So we really didn't have a ton to add. I mean, the first question, could this occur in your system? It is occurring in our system. So we had a group where we were child welfare people or a person who worked for providing services to children whose caseloads often overlapped with their child welfare system. So, I mean, it is occurring in our system. We see it all the time with frequency, regularity, where we have people who, we've had people be fired, let go, and, it doesn't take a lot of that for the rest of the staff in the entire state to see without having to be told. In terms of our system response, we've talked the same thing about what everybody else has said, is that there was a lot of shame and blame, and we actually in Oregon had HR in our systems response, and so we from the get-go made it very clear that there was a very, very high probability that you could have HR action. In terms of how we felt, if this happened in our caseload, we had similar responses. I think people felt devastated, stressed, worried, all the things that we always feel. And I think we actually had a conversation with one of our staff about how they actually felt like they weren't allowed to grieve because they were so self-consumed with all of the worry, and that in and of itself was really stressful. And the impact, what was fascinating is I think because there was so much conversation about how we had defined accountability in terms of it being specific to firing a person, that there, with as much change in rules and policies and legislation, that actually there really wasn't an impact or a change in the way that we would hope that there would be change. And so even though you're doing all of the stuff to create change, you really don't see it. What you just see is more firing and stress with staff.
Yeah, that's awesome stuff. A comment came to me when I was listening to Amani that I didn't make because I kind of froze up and couldn't remember what I was going to say. But the way in that clip, I was talking about the media and I hated to single them out. The way in that clip when they cut back to the anchor and she just reports the suicide as if she's reading the weather is really upsetting. And it really, again, like so many things in that news clip, it just sort of, if you were in that workforce, you'd feel I would think, devalued. Not to mention if you were a family member of that professional who got up that morning not knowing a kid was going to die on their caseload and hoping to do good work and help families, right? It's really a sad piece of that clip. All right, last group, group 6, team 6.
So that would be me. It's always hard to be the last group and to report out without sounding too redundant. So much like everyone else, from 1 through 5, we had very similar responses to those questions. I think in our group, we had individuals with some diverse experiences, both from like the UK, Los Angeles, myself from San Bernardino, and we all agree that this is something that could potentially occur even within our settings, or the likelihood of something like this happening. And that the knee-jerk reaction tends to be either to make very sweeping, large-scale changes, sort of like, I think one person that stood out to me was, I think the Secretary of State or some, went into talking about widespread policy changes, or in the other direction, making shifting the blame onto individual workers and things like that. So I think what stood out to all of us was the need to sort of really looking at it from a more pragmatic and systematic exploration of maybe what went into into incidents like this from happening. I think that would be trying to help organizations also looking at seeing what were those particular factors that contributed to cases like this. And I think, like some individuals had highlighted previously, it does create this reaction of people or workers becoming more risk aversive, but in reality, they could be several cases that maybe we've had that have very similar factors that went into a certain line of decision making, but that outcome may not necessarily be the same outcome as this. But it does definitely blur one's reaction once something like this happens to the way we all respond or react. So I've summarized that all in a nutshell, but that was some.
That's great, Priya. You gave me, it's a great segue actually to my next set of slides, but this idea of what you just brought new to the conversation was this idea of systems having a way of looking at those system level influences, not focusing just on a professional not following a policy, but trying to understand, one, what prevented them from following that policy, and two, is the policy even the right policy? Like, how do we really understand those kinds of dynamics and interactions in our system? Okay, so I promised you guys a break. You want to do, we have 30 minutes. I have about 5 slides left and then another little activity. Do you want to do just 5 minutes to stretch, and then I'll come back and do the slides? You can turn your camera off for 5. All right, 5-minute break, and we'll come right back. Okay, I think I'm going to start so we can wrap up. You guys, those of you on the East Coast, this is a late day. Is there anybody here on the East Coast? I can't remember. May not have been. You are? Oh yeah, were you from New Jersey? There was somebody from New Jersey, I remember. Oh yeah, and then the South Carolina crew.
Tennessee.
Yeah, it's like happy hour. Feel free to drink if you want to go ahead and wind down for the evening. All right, I'm going to get started. I'm sharing. Somebody needs back in. There was some good stuff in the chat. If you guys want to go take a look at the chat box, people putting a couple of comments in there. So I'm going to just talk really briefly, a couple of slides about one of the tools the tool that I mentioned at the beginning, the SSIT, and how we think about using it in systems and how it helps support the kind of culture that we've been talking about, and sort of a different response to things like child fatalities or a suicide potentially, or some other critical incident or high profile thing that happens in our systems. And so the Navajo have this tradition of making baskets, and they call these baskets, in the process of teaching people how to make them, this idea that it's a culture carrier. So sort of metaphorically, it is a carrier, it carries things, but you could make in 2020 a basket more efficiently and effectively and faster by not training people to make it by hand. So the act of making it and the process of training them how to make it, the new folks who are being initiated into making baskets in that tradition, and creating these baskets, it carries their culture forward. It allows them to pass it down to the next generation of folks. It helps them put into the process of creating baskets all the sort of values that they want to promote, pass down. Remember, culture is about our habits. It's about what we teach to new people that come into our organization. And so really like this metaphor of a culture carrier in the tradition of creating Navajo baskets. So what are places where we can put all the sort of values that we just talked about, creating a system that's about learning, that's not about shame and blame, of balancing system accountability with individual accountability, being about continuous quality improvement and learning. How do we get all those values into like every nook and cranny of our culture? How do we put it into things that will help us sustain it as a culture carrier? And so the work of creating a culture like this, doing this kind of work, creating a safety culture, kind of organizes itself around 3 strategies that are interrelated. And we're doing work with a bunch of jurisdictions around the country, several of you that are on the call are participating, around these 3 strategies. And we're leading with helping them think about their approach to doing critical incident reviews, or specifically how they respond and review child fatalities. So how do we bring a systems lens to that process? And so I'm going to describe that process to you and describe this new tool that we've been using that's now part of the TCOM suite of tools. But think in terms of this process as a culture carrier, because that's how we thought about it when we developed it in Tennessee. We had these big, lofty goals around creating this kind of culture that we learned about through our work with the Medical Center at Vanderbilt, but that we knew was effective in helping other safety critical settings be more safe, reliable, and effective. And so we literally thought about this process of creating a new child death review as a culture carrier. It's the place we're going to put all these important values. It's high profile. In the Tennessee system, it reported to senior leadership, so it was kind of close to decision makers. It was, well, I said high profile, but it was high profile in a couple of ways. It was high profile within the institution because you were doing these reviews, but obviously outside of the institution, it took on a greater importance when something bad happened, potentially. So how do we embed into that high profile process all these values of a safety culture so it can become a culture carrier, so it can help move the culture? So we created this system-focused approach to doing critical incidents. That means you think differently about human error or practice variability. Human error is the language that comes from the literature, because most of this work is done in places where there's identified errors. The person, when they introduce themselves, that works in the mental health agency that's Joint Commission accredited, Joint Commission has a set of errors that hospitals and outpatient centers report. Medication errors, falls, retained foreign bodies in the operating room. Those kinds of things are established in healthcare. They report them, they know what an error is from that perspective. We don't really have that in child welfare, not even so much in a behavioral health setting. So we don't have an agreed upon set of things that are like that we report. So how do we think differently then about variability in practice, or this idea of human error? So first, you come at it from this perspective that it's no longer seen as the cause. That case manager not following a policy didn't cause that death, right? Which is what you would take away from that public information officer's statement, was that somehow someone didn't follow a policy that led to, therefore, this bad outcome. We don't view those kinds of things any longer as the cause. We view them as a symptom. Why was the policy not followed? What got in the way of that practice that we hope to see happen not happening on that day? Or was it the wrong practice? So then, therefore, it's not the end of our inquiry. It becomes the beginning. It's where we start interrogating our system and learning about it. We don't see it as a cause, we see it as a symptom, and it doesn't end our inquiry when we identify these things. It just opens up new paths for us to go down to understand better with more complexity the things that are going on in our system. And then we can't think about these things as random or isolated events. We have to assume they're going to happen again and that they're just an emergent property of our system. There's something about the way that our system works. Somebody actually, Priya teed me up nicely because she said something just like this idea that, you know, we assume it's just one caseworker doing something wrong or even if unintentionally, and we make the mistake then of thinking, well, if we just correct that one person, we sanction them, we get them out of our system, we write a new policy and we train everybody, we're going to keep our system safer. But what we should be thinking is this is an emergent property. This is something about the way our system interacts, all the little components in our system interact, and something that emerges from those interactions. It's an emergent property of our system. So you have to bring a systems lens then to doing your critical incident review. In building this culture carrier, we had to think differently about the steps in our review process. Most importantly, it could no longer just be a retrospective review of the case record, because we know that's fraught with mischief. We're really biased with this idea of hindsight bias when we do record reviews. We look back at a case record, see all the things that did or didn't happen, and we put them together in some logical way that just didn't exist in real time when people were actually making decisions about the case, because they didn't know the outcome, right? They didn't wake up that day knowing what was going to happen at the end of the day. So when we created this new process, we wanted to embed these new values into this process so it could become this culture carrier, this high-profile thing that helped us drive culture change into our system. We had to create this opportunity to go talk to the professionals who were actually involved in the case. We needed to take that otherwise sterile record review, the things that we learned from reviewing the record, and go contextualize it with a conversation with the people who are actually making decisions on the case, and importantly, they were impacted by what happened in the case. And so we created a process of debriefing professionals who were involved in the case, actually understanding and contextualizing. This is the work of understanding local rationality. And local rationality is sort of the opposite side of hindsight bias. If hindsight bias says, when I look back at things, I'm biased to put them together in a logical sort of sequence, understanding local rationality is about going then and understanding decision making. And it would say that people make the decisions they make because it makes sense to them at the time. Otherwise, they would make other decisions. So that's not a value judgment. Their decisions could be right, they could be wrong, but they're making them for a reason. And what you need to understand as a systems thinker is why they were making those decisions. Because, again, to Priya's point, we can't assume it was one person making one bad decision. We should assume it's a systems issue and it's going to plague other folks in our system. Other people are going to step in that same pothole. So we need to understand it better and contextualize it. And then we need a tool to, just like the CANs, helps us put that one family story together with other family stories so we can identify those trends that we're thinking about. We need a tool for standardizing the output of this process so we can string these stories together, identify trends in our system that are about systems problems and not just about professionals doing bad things. And so we worked with John. I had actually started working with John Lyons when I was at Vandy to help develop this tool for use in hospitals for root cause analysis. So that's another Joint Commission requirement. They require a root cause analysis on a certain set of things that happen in hospitals. And then they actually report that data back up to the Joint Commission. So we created the Safe System Improvement Tool, what became the Safe System Improvement Tool. Didn't get much traction actually in a hospital context, but we were able to use it in the child welfare system in Tennessee, and now other jurisdictions are starting to look at it and use it. So it helps us standardize a set of systems influences as an output of that review process. Again, it also, the way the tool is structured and the way the reference guide is laid out, it reinforces all those important values and principles. So to the point of creating a culture carrier, we embed all that language into the process, and language drives culture. So just like when you, as a behavioral health provider or as a child welfare system, you went about the process at some point probably of becoming trauma-informed. Becoming trauma-informed as a system is as much about, one, changing your paradigm, but two, changing your language, using different words, talking differently about that externalizing 13-year-old in your juvenile justice system who's blowing up their placement but has a significant trauma history, right? it becomes about what happened to them. It becomes a different way of talking and viewing that kiddo. So this too is about a different language, and you can embed that language into your culture carriers, into things like your systems review. So here are the system level items that we capture in the SSIT. We also capture some child and family level items that are just borrowed over from the FAST. And then this is kind of what the output oftentimes looks like. And again, the idea is, this is from Tennessee's public facing report. They've done 73 of these reviews that we put into this slide. And this was the standardized output of those reviews. And so what it allows a quality improvement team to do inside a system is string together these stories, turn it into data so they can advocate for change inside their system. Because ultimately, quality improvement professionals doing this work, trying to help a system identify opportunities for change, they're advocates. They don't have direct line of sight over the people they're trying to get to change. They need tools to advocate for change inside their system. All right. We are right at time, 10 minutes. So let's take 5 and just quickly do this other activity and come back. So I'm going to try to make this work. I've got 2 questions, and I'm going to try to paste into a personal chat directly to Lauren. And then, that was a joke. And then let's go answer these questions and see if we can quickly come back and report out on them. I'm going to run out of time because I can't seem to work PowerPoint. All right, so the essence of the questions is, think about a time when you made a mistake. How would you want the system to respond? And then how could we identify some culture carriers? What kinds of things could become culture carriers that we might have the influence over working on and embedding these important values into? All right, so headed back to the breakout room. Okay, so I'll just ask again for a little grace in this new training environment, and I had a little more material than we had time for today. So do a couple of people just want to volunteer and report out on if they had any really interesting aha moments in this last breakout?
I'd like to share if I can, Mike.
Yeah.
So I think we talked about, having made a mistake and wanting to be given the opportunity to share our story, like be heard and respected, and that the story of the incident be shared from my perspective, like that the story come from me, and I think that was really invaluable. And we talked a little bit about the parallel process about like our families and how that really is, we have so many times that we think we know the story of the clients that we're working with, but the value that comes with giving them the opportunity to share what they think happened, what led to, the events that led to such and such situation. And, that we sometimes just tend to jump to trying to, the solution, that we don't really ever get a chance to look at, well, what were the events that led to what happened, so that way we can actually prevent it from happening in the future. And the other things that we talked about were, if you don't really have like that supportive environment of being able to share when you have made mistakes, then what winds up happening is that when mistakes happen, you don't share them, right? Like I joke that it's like, I've made tons of mistakes, but how many have I actually revealed to my management? Not as many, right? And so I think that's kind of the same with our families. We want to model that, you want to be supportive in that environment. And so one of the suggestions we talked about in terms of that cultural carrier was to just model that transparency, within our organization, that it's okay to be transparent and not like what somebody was talking about, like the CYA mentality or trying to sweep it under the rug, like get it out of media, get it out of, we're moving on. But to really stay transparent about that these are the things that have happened. And it really kind of, again, models a family. It's just part of your story. It's your part of your story as an organization, that this is where we were, we had this situation, we learned from it, and this is where we're at today.
Yeah, it's so important. And we so often, especially in response to things, and I talk about this when I do CANS training, none of this stuff is unfortunately about identifying some objective truth. It's about storytelling, understanding people's story from multiple perspectives so we can go do work. Okay, so we're at time. I want to honor everybody's time, but also I want to honor that if people really want to talk about what they just learned in the breakout room. So what I'll do is I'm just going to hang around, and if anybody wants to hang on and talk or report their story, but I 100% understand if you want to just bail and be done because we're at our 2 hours. Does that sound okay?
And Mike, if you just want to make me the host so I can share that last screen with everyone, which has the CANS, the conference game passcode on it.
You know what I do to make you the host?
Just click on the little dots and say make host.
You make it sound easy, but I'm not dot.
Oh, next to my face tile, my tile.
I've got you in speaker view. There we go. Works in gallery. Does anybody want to talk about what they learned in their group while we're doing this?
I think I do want to share because it came up in our first breakout room as well, and just thinking about the culture carrier in your community to shift the idea that child safety is solely the responsibility of child welfare, that it's a community that keeps children safe, law enforcement, schools, public health. There's a million more I'm not thinking of. And I gave an example in Sacramento County how the CPS oversight committee that was chartered by the Board of Supervisors really embraced that. And through those reports, those oversight committee reports started becoming a good thing to shift that perspective instead of just a laundry list of what we were doing wrong in child welfare. So and really partnering with law enforcement, I think, is a key relationship to shifting that culture.
That's awesome. Yeah, Sacramento does a nice job. I get to do some work with them on another project. So Scott and I are going to head down to Bourbon Street.
I forgot until you mentioned that, Scott.
I just want to ask, how is it that someone already has 945 points? Because, I'm super competitive. So what's going on with the 945 points?
I think people are just like guessing words and like seeing if they're codes.
Thanks for that, Sarah. Does anybody else have something they want to share?
I could add a little bit from our group, and it was really just about how much the direct care staff ruminate about the past and the future. Thinking back years ago to I was in a situation that if, A, B, and C might have happened, this could have turned tragic. And I thought I was doing my very best at the time, but now with the wisdom I've gained over these years, I look back on my younger social worker self and say, oh my God, that could have gone way wrong.
Yeah.
And also looking forward at the future saying, I've got a high risk case right now where, this teenager's attempted and will again attempt suicide, but in a more reckless way kind of each time. And despite communication to supervisors, despite communication with hospitals, this kid is such high risk that eventually something is really just likely to go wrong. And, the thought of ruminating, like, I don't know what else I could possibly do.
The ruminating is such a great word. In the high reliability literature, they talk about systems having a constant wariness, systems that are really effective at like recognizing things that could go wrong and responding to them and then coming back to normal operations. So that practice of doing that is called mindful organizing in the literature, and we talk a lot about it. I'll talk a little bit about it in my keynote tomorrow. But I was just reading a new article that I hadn't seen before about it, actually written by a good colleague of ours. But it talked about teams that were effective at this, people on teams who were effective at this, like, kind of predicting risk and what might go wrong, and then reacting to it and then coming back to normal operations. They had two qualities. They were pro-social, so caring about your colleagues matters. But they were also had what they described as emotional ambivalence. And I think it's kind of what you're describing, Scott, when you get more, experience in the field. And the emotional ambivalence that they described was about two specific emotions, doubt and hope. And so it's like people who can toggle between doubt, being a little skeptical, and hope, being kind of optimistic that things are going to go well. are those qualities are seen in teams that are really effective at doing this thing called mindful organizing.
Excellent.
Did anybody else want to share?
You know what I was thinking as you were talking, Scott, is that, you know, we talk so much about like the trauma-informed care with our clients, right? And it was mentioned through the discussion here that like we don't really have a chance to grieve or mourn the loss, right? Of like when we've lost a client, whether a child or another, you know, client of ours. And so we're not really giving ourselves the opportunity to practice that same trauma-informed care with ourselves. And so that leads to that ruminating or the doubting, you know, and it's kind of like we had to move on so quickly. And we all know, right, that a traumatic experience doesn't just happen the one time and then it's done. It's like, so I think that that's part of why you do have that doubt of like, you know, you doubt your abilities as a professional, you know, because I didn't get a crystal ball when I got my degree, you know, and so it's like, these are the types of things that, again, that parallel of modeling that trauma-informed care for ourselves as practitioners too, like bringing it up even after it's been a few years ago. Hey, have you thought about that recently? Has that still been impacting your work in any way?
Love it.
This is Molly. I'm from Oregon. I thought I'd share something. I just sent Scott a private message because we've done a lot of implementation work around suicide prevention and awareness. And so I was in charge of kind of spearheading those efforts, and I happened to be doing it at the same exact time that we were implementing the use of the SSIT and safety science in our critical incident review process. And so it was a very interesting dichotomy when you looked at how we responded to children who were dying by suicide and children who were dying from a variety of other things. And, you know, I think what was fascinating about it is that for whatever reason in Oregon, there was never a shame or a blame process with suicide deaths. Don't get me wrong, there were some cases where we had some sorts that there was a suicide attached to. But for the most part, when we responded to a child who had died by suicide, there was a different response. There was a level of support, a lack of accountability in that way. And so we started this whole process where we did a lot of implementation of a particular program. And because of that, we've had significant amounts of suicide prevention intervention work that has gone really, really well. We have staff that feel extremely good about it. We've had multiple stories of people having individual accounts of doing and going and doing the work and feeling as though we have a survey that's come back where they actually feel like there's been improvements to our systems as a result of this. And I say this cautiously, but what's really interesting about it is I don't necessarily know that we're having a decrease in suicide. And I wouldn't say that that's the whole purpose of all of the outcome of it. But what I would say is that people feel more empowered and people feel more able and willing and ready to intervene and to make steps to possibly prevent a child's death. And, you know, I think that the data is still out there, so it'll be years before we know if there's ever been like a real significant impact. But what I know we have impacted is staff. And it was just a fascinating thing as I was sitting here listening, because I'm like, we were running these two systems at the same time and watching how different they were. But the reality is that they were serving the same population with the same staff. Yeah. And just how fascinating it was to see the difference in that.
And you know, that's the story of suicide prevention nationally. You know, we do a lot of work and doesn't seem to bend the curve. And it's like child maltreatment fatalities, it's a low base rate event, and you know, a couple of suicides. I mean, you know, it's just hard. It's really hard. Anybody else?
We will. Our group, we talked a lot about psychological safety, of course, in the response, and then also about coaching and using coaching around the mistakes that we make. But as far as the culture carriers, without knowing, people started naming stuff from our safety culture toolkit. So someone was doing weekly huddles, you know, highs, lows, what's going on currently. They meet the same time every week. We talked about how important it is to have your voice, and how it is easier when you feel psychologically safe, but how important it is, you know, to check in and understand with those things. And promoting culture coaches is something that we've tried to do in Tennessee. and placing people throughout the state to promote that within their own regions and their own teams too.
Yeah, that's a really intentional kind of culture carrier strategy. So much so that we name them culture carriers.
Yeah,
So
exactly.
The toolkit she mentioned, we developed this, we call it the field guide now, and it's a little bit different than the version that we first developed in Tennessee, but we work with KC Family Programs to do a Breakthrough Series collaborative. And we just took things that came out of crew resource management. Scott, you would have read about it in Checklist Manifesto. Things like huddles and debriefs and checklists and using standardized communication tools. And we tested them in a child welfare environment and then put them together, kind of curate them. Healthcare calls it Team Steps. It's their similar curriculum that they've developed. Anybody wants to reach out, I'm happy to share it. Okay, anybody else? All right, thank you guys so much for coming.
Mike, I have a question. Has the SSI tool been used like with residential care facilities? So
we have not done, well, it has in the sense that child welfare systems with kids placed in residential care where a fatality happens, they've used it in that way, but not the agency itself using it. But we're actually going to start working with a jurisdiction, a state that's doing some reforms in their congregate care, and this is one of the things that we're probably going to bring to that reform. So
okay, awesome. Because I see, here in LA County being now part of the out-of-home care team, we typically get involved right when there's like an investigation or, repeat agencies unable to or unwilling to meet the needs of the kids. And it's like they get clumped into like good agencies versus bad agencies. And I'm wondering, it's like, if this tool might be beneficial to help them, help kind of evaluate, like you're saying, from a systemic point, because typically what tends to happen is these agencies will then just pin it on a particular staff person and they replace the staff person, right? And the same repeat behaviors keep happening. Yeah. And so it makes it look like it's more systemic. And so that's kind of, I was just wondering if there was any work with regards to being able to use that tool within residential care or even like foster family agencies.
Yeah, it should fit perfectly. I mean, it should translate perfectly actually into a residential care setting. It's probably more appropriate than, it really would fit well there. A couple of you just posted questions about the SSIT. If you just want to reach out to me, I don't know if you can do that through the Socio app or I got logged in through my Gmail account, which you're welcome to email me there, but it's also just michael.cull@uky.edu is my Kentucky address. But so I'm happy to share the tool with you. You can find it on the TCOM site. You can find information out about it on the Parade site, rather, if you just go to the Parade Foundation's website. But specific to your question, Kelsey, we're doing the work right now of establishing inter-rater reliability, which would actually make it fairly unique as a tool used for things like root cause analysis. And you wouldn't measure any kind of real validity because you're not predicting anything. So that's when you talk about a tool for looking at critical incidents, it'd be great across the system to know that there was inter-rater reliability, that everybody used the tool in the same way, but you're not predicting an outcome with it. So you wouldn't do really tests of validity. The scales we use, you may be interested in, because we took, but you could also use the healthcare ones, but we took safety culture measures from used in healthcare, validated them for a child welfare context, and put a paper out in the literature. So be happy to share those with you if you want to reach out to me. All right. Well, thanks, guys. This was really fun.
Thanks, Mike. Yeah, it was awesome. Thank you.
All right.
Thank you so much.
See you around the conference.
Yep.
Bye.